Hello, welcome to Doc Talk Live. Good evening. I'm with Paul Snow. Paul and Christy helped me with building Doc Talk Live. They're with Moxie, and Paul basically came to town today from Louisiana to help us actually grow Doc Talk Live. And if y'all have any thoughts on how to grow Doc Talk Live or shows y'all want to see, please go ahead and somehow connect with us, message us, get Christy, who helps us grow the show, but message us if you can. But anyway, Paul's been having problems with his back, and so I thought we would try to bring what we do in terms of evaluating spine, and try to build something here. And then tomorrow our plan is probably going to be to do a procedure, but I wanted to sort of not get too much information from you up front. I wanted to do it for our viewers who maybe, and if there's questions, if people are watching this on the live feed, please go ahead and type in questions. So go ahead, Paul, give us a little bit of what's been going on with your back.
So do you want the history from the beginning?
I want as brief a history as you can give me. But yeah, the beginning is fine. Wherever you want to start.
Okay, so at a younger age, out of college, I was mountain bike riding, flipped over the handlebars aggressively, and had to go and get my shoulder looked at and my lower back, and did some injections then. I was, I guess, fairly young, so it healed itself pretty good.
So how old were you?
I was 26, 27.
How old are you now?
Almost 50.
So this is 25 years ago.
Right.
So the first thing I notice is as far as this traumatic injury on a bike is I don't see any fractures in your back.
Right.
So when I think about, you were in this sort of trauma, I'm just looking at your MRI of your spine. I don't see a fracture. Okay. So do you get over this injury, or do you have lingering problems?
So at that point in time, I got over it.
You got over it. So now fast forward for me then.
8 years, 10 years.
Okay, so now that brings us to 35 years old. What happens?
Very active.
Okay, good.
Tennis, race cars, and I do other things.
Is racing cars considered being active?
Very.
Like that doesn't. Seems like the car is active. You're just sitting there turning a wheel, but.
I'll let you ride sometime.
All right. So anyway, you're very active racing cars.
Yes. And sports.
Okay. And so what's going on with your spine at this time? Your back.
So at that time, I injured it again.
Okay.
And went back, and it seemed like it just took a lot longer.
Now, when you say you injured it, you described this bike accident. That sounds like an injury. Mm-hmm. But now, fast forward 10 years, you say you injured it. Maybe it just started hurting.
Okay, so I disrupted it again.
You developed back symptoms.
I irritated it again.
Okay. So you don't know exactly what you did. It's not like you fell off your bike or crashed your car.
Yeah, no, I did that.
Oh, you did do that?
Yes.
Is that what you associate your symptoms with?
No, I think it's just a matter of time. It got to be the same thing in the same place, and it took longer for it to heal.
Okay.
So as I got older.
So you have a back attack, let's say,
Mm-hmm.
but it does heal.
It did.
It did. And so you'll go, let's say, a year, 2 years, 6 months.
So the past episode was about almost 2 years ago.
So 2 years ago, but 35 to 45, you would have, let's say, episodic back pain.
So no, I would actually just go to the gym and do 15, 20 minutes of stretching.
So you wouldn't have any back pain?
Every day.
So you're pain-free for 10 years, 15 years, 20 years.
Right.
So then 2 years ago, so you're doing well up until 2 years ago.
Right.
When what happens?
I'm driving really fast, and I get jarred around a lot.
Okay.
And it just did something.
And so since then, you've been having pain in the back.
So now I got better, and then again, I'm actually working on a car. Mm-hmm. And I'm in an awkward position for a prolonged period of time.
Absolutely.
And I'm holding that position to like loosen a bolt or something like that.
Sure.
And that's when it caused me to start feeling something, and then it got worse.
And how long ago was that?
That was 5 months ago.
5 months ago. So 5 months ago, if I saw you a year ago, you would have been fine.
Right.
But 5 months ago is when this is when you started bothering everybody with your back, like I can't do this, I can't do that, and it's been going on 5 months, and I believe you had an MRI. Obviously, you had an MRI of that here. We'll get to that.
Yeah.
But you also had a couple of pain blocks. Is that right?
I had injections. Yes.
Injections.
Yes.
And tell us a little bit about those injections.
All right. So what I did wrong is, or what I was told I did wrong. I went in and got an injection without getting a new MRI, and what I didn't realize is I had some lower S1 fatigue as well, I guess.
Okay.
And so I think the first time I did that, they might have missed where it was, because I didn't get a new MRI.
Okay.
They might have missed the location.
Okay.
So then nothing, no relief. Went back in again for two MRIs, two procedures in two different places. It did nothing. So this is probably the worst it's been so far.
Okay. And what are your symptoms?
As far as aching,
Like stand up, show us where you hurt.
well,
Show us where it goes.
so stand up, I'm pretty much leaning forward
Okay.
and have to walk like this to get somewhere.
Okay.
And wherever I find somewhere to sit, I immediately sit down.
Okay, so you prefer to sit.
Right.
Okay. And turn around and show me where you hurt the most in your back.
Well, it's just a running all the way to my foot.
So it runs down the leg.
Yes.
The left leg or both legs?
Left only.
Only the left leg. And you mentioned some weakness. So first I want you to walk on your heels. Can you walk on your heels? Good. No problem with that.
Right.
And now can you walk on your toes, on your tippy toes?
Yeah, but it's I'm
It
feeling
feels weaker on left. Like if I'm going to hold on to you for support, but I'm going to do a toe up.
Okay.
One leg, and then I'm going to switch legs and do a toe up.
Okay.
Okay, now you can hold on to me for, so it's not a balance test, it's a strength test. So you're coming up on on the right. Do it again, do a few of them.
Okay.
Good. Okay, now switch feet. Now let's do the left leg. So that's weak, right?
Very weak.
I gotcha. And that's where the S1 comes from. That's why people are telling him S1, because the S1 nerve is generally thought of to supply the electrical wire to the gastroc muscle, or the muscle in the calf, and that's what allows us to come up on our toes. Now you mentioned something that was interesting. You said that you're more comfortable with sitting.
This time.
Because usually people are less comfortable with sitting.
So that was the reverse of the prior time.
And so at some point, I believe you told me before Doc Talk Live that you, because you failed these injections, that you were referred to see a surgeon. Is that right?
Yes, I was a surgeon. I was also offered drugs.
Okay.
That I refused to take. And
Okay.
then,
But you've not seen the surgeon yet.
no, because I think it was more of an insurance procedural thing where you had to do so much before you could go that next level.
Okay.
You know.
So the couple things that I would like to try to discuss with you that hopefully will maybe or maybe not facilitate questions is what is potentially going on, what is the diagnosis, and then also what are some of the various treatment options. Okay, so if we start with the diagnosis, the question is where is Osama bin Laden hiding? Osama bin Laden, 2001 blew up the World Trade Center, and he was gone for, we couldn't find him for 10 years. So we had all this spy data, to try to locate him, and we ran all these missions to try to find him. All of them were unsuccessful until 2011 when they sent in SEAL Team 6 to a particular location. So it's the same question here is where is Osama bin Laden
He's
hiding?
between L4 and L5.
And how do you know that?
I don't.
Because I think he is, but we did a show this week on pain, and we talked about how complex pain can be, and the fact that sometimes we get a little bit too localized, and we don't think about the entire body. But truly, when I evaluate and treat patients such as yourself, I am looking for a very focal, localized process
Right.
to try to define what's going on. So this is a picture of your back from the side. It's a side view. This is an MRI. This is the sacrum or the tailbone. These are the vertebrae. This would be the fifth lumbar vertebrae, and they go 5, 4, 3, 2, 1. In between the vertebrae are discs, and the discs are shock absorbers between the bones. And the discs are sort of the structure that is not only designed to keep your spine stable, it's also designed to allow your spine to move. So it's designed for not only stability, but mobility. Which when you think of buildings, buildings are straight columns generally. They're not these curved structures. And the reason they're not curved is because you want to plant them in the ground and you don't want them to move, okay? Mm-hmm. So because our spines are geared not only for stability, but they're also geared for mobility, we have this very specialized structure that allows for stability and mobility at the same time. And like a shock absorber, they wear out over time. And a normal disc generally has this sort of bright nucleus called the nucleus, and it's like a jelly donut. The white stuff is the jelly, and the dark stuff around it is the donut. But as the discs degenerate over time, they get dark. They lose water, okay? In this disc, and it's very subtle, this L45 disc, the back of the disc is coming out, and it pushes ever so subtly on the nerves between the joints in the back and that disc. So if you look here, you can see that there's a lot of room for the nerves, and then right here things get very closed down, and then they open back up again. You follow me? And so that's where we think that the nerve is being pinched. Over here is a cross section. So we've taken a slice through your back. So if you think of your back like a tree, we've now cut the tree into a trunk, and we're looking sort of down at the back. We're not looking at it from the side, but we're now looking down. And this red line is corresponding to this little piece of disc right here. And this is where that little piece of disc is coming out, and it's hitting the nerve. And this is more typically the L5 nerve, but it could be the S1 nerve because they're all cramped in that little space that goes down your leg. So I would agree, based on your symptoms, it appears that this is where Osama bin Laden is hiding. You follow me?
Right.
In your back. And so there's 4 things that people do to try to treat the pain, okay, in general. They do surgery, they take drugs, they have drugs injected, and they do physical therapy.
We're going to live with it.
That would be the 5th thing.
Right.
They live with it. And that would sort of be what I talked to Dr. Dolays about this week, about how you manage chronic pain, how important it is to keep race car driving or to keep playing tennis in spite of the pain. You have to stay functional even with the pain. But if we put that aside for the moment and we think about those 4 things, surgery, take drugs, inject drugs, physical therapy, we should go through those 4 things. With physical therapy, in general, what you're trying to do is you're trying to push the disc back into place. And unfortunately, this disc has already sort of slipped out. So it's going to be really hard for a therapy to put the disc back in place. But what therapy can do is it can build up the muscles that surround your back, the filet mignon, the core of muscles, and that's what's called spine stabilization exercises. We're trying to build up that core. But is it really going to push that disc back into place? Not at this point, okay?
I can tell you that.
Your body, though, over time may dissolve that disc that's come out. And so a year from now, if we got a new MRI, I would expect that this extruded material that's come out to have resolved, okay? I would also expect your strength in that leg to improve, because even though there's nerve damage, those nerves over time do grow back. Okay, so you should over time recover a lot of that lost strength in that leg.
So why does the nerve feeling change?
I'm not sure I understand that question.
So in other words, I might feel a stinging sensation.
Okay.
And it might be numb the next day.
Okay.
Or it might be more at the bottom of my foot. It might change to more.
That's an interesting question. And so to me, what that gets at is the various types of referred pain. So all back problems in general cause referral into the leg, okay? When you have numbness in the foot, it's probably due to the nerve itself being irritated, okay? But when you have sort of this dull, achy pain in the hip and thigh, it could be just from the arthritic degenerative change itself. Think of the heart. When somebody has a heart attack, they complain of chest pain that refers into the left arm. The left arm pain is not a pinched nerve. It's the heart muscle itself referring pain down into the arm. So it could be that the spinal discs, the spinal joints, the muscles or myofascial structures refer pain into your leg. And you could also have another referral from the irritated nerve itself. So you may have two different sources of referral, okay?
Is that the same as before I couldn't stand up and now I feel better sitting down?
So most people with disc problems actually are worse sitting down. And so it could be that you're better sitting down because when you're sitting down, you are allowed to bend over, versus when you're standing up. You remember when you said you stood up, you tend to walk like this, you tend to walk bent over? It could be that because this disc is occupying some of the space inside the canal there, that by forward bending a little bit, you're opening up that space. And so you're describing what people tend to classically have as spinal stenosis. So that's a little bit complicated, but I think that's why you prefer to sit, whereas most people with disc problems hate sitting. And the reason they hate sitting is because when we sit, it increases the pressure inside the disc, okay? So from a surgical perspective, we talked about therapy.
Right.
From a surgical perspective, and I'm not a surgeon, okay, but what I think many surgeons might do is they might remove some of this tissue here to work their way inside the spine and take away that disc. So they would make the spinal canal bigger, they would decompress that area, and they would cut away the piece of disc that is extruded, so-called discectomy. So that's your classic laminectomy, discectomy. And that would be a surgical treatment, and that's like sending SEAL Team 6
Right.
in to destroy Osama bin Laden.
So how long before I go down that path?
That's a good question. I would suggest you go down that path when you fail everything else,
Okay.
which is physical therapy, injections, or minimally invasive procedures, and medications.
Mhm.
Now, I'm not a strong believer in medications for this problem. In my hands, I haven't had any success through medicine management. My patients will tell you that I don't work with them really on medicines for this.
Right.
A lot of stuff is available over the counter, like Advil, Aleve, Tylenol, things like that. But as far as taking opiates, I mean, a lot of people do take opiates for this problem, but we have an opiate problem in our country. And so, I would prefer to save that for another doc talk because that's obviously an important topic. But I would discourage you, and you don't want to anyway. You said, listen, I'm just not taking drugs for this. I don't want to get hooked on drugs. So it's not a great avenue for this. However, there are medications that people do take for this, for the nerve pain, for the aching pain, for the various pains. So that leaves us with injections.
Right.
And so from an injection standpoint, probably what you've had done, basically putting medicine in the epidural space. And the epidural space is this space that surrounds the spinal nerves, okay? These spinal nerves are bathed in spinal fluid, so the fluid is the white stuff on the inside. We're not putting the medicine inside the spinal fluid. That would be an intrathecal injection. We're putting it around the sac. That's an epidural injection. So epidural is around, subdural would be inside the dura, or intrathecal, same thing. So what they've tried to do is put medicine around the nerves and around this piece of disc. The only thing I would do differently at this point, and this is a bit controversial and not commonly done, which is why I encourage you to come up here and see me, is I would, at this point, given that you've failed a few blocks already, is I would put medicine directly into that ruptured disc.
Gotcha.
Whether or not it would dissolve the disc or decrease enough of the inflammation to alleviate your symptoms we'll just have to see. If it doesn't, are there other non-surgical things you could try? There is something called Superion for spinal stenosis, which is sort of a jack in the back that would sort of flex. It would flex this level. Everything else would stand up, but that level would be flexed over.
Is that a procedure or something you do?
It's a procedure that we do. It's only covered for Medicare patients.
Okay.
So the problem with that is you're not old enough. But just for thoroughness, there are other minimally invasive things that could be considered. And the reason we would consider Superion is because the fact that you get relief in flexion by being bent over a little bit, we can flex that open a little bit by putting a little jack in there.
Okay.
That is something to consider. Another minimally invasive option is a spinal cord stimulator. It's like a pacemaker, and it's basically interrupting the pain signal from reaching your brain. And I would tend to push you more toward a surgical treatment than a treatment that's just going to mask the symptom, especially if this could be corrected with surgery.
And I've heard the word rhizotomy a lot.
Rhizotomy. So rhizotomy doesn't really apply to you. Rhizotomy or radiofrequency is where we burn the branches of the nerve to these facet joints.
Okay.
And if you were having just back pain and you weren't, and we knew it was coming from the facets, then yes, burning the nerves to the facets would be good. And then the other procedure, relievant, is basically a rhizotomy inside the vertebrae, above and below the disc. You're trying to take away the innervation to this disc. And so those are treatments designed for back pain. But your problem seems to be this extruded disc here, occupying space in your spine where the nerves go down your left leg. So burning the nerves to the facet joints or burning the nerves above and below the disc is not really going to address this little piece of tissue that's hanging out in your spinal canal. You see what I'm saying?
Yeah.
And so that's sort of the guts of it. Do we have any questions in there? Are we good?
So on my report, there's a couple of terms that were used.
Okay. You want to pull that report out?
And that I wasn't really familiar with. And I think it's spinal stenosis, I think.
Spinal stenosis.
Yeah.
So we talked about that. And stenosis is basically a narrowing in the spine. It's kind of like when your shoe is too small for your foot, you know, and like for instance, I walk around with my shoelaces untied. And the reason is my foot is too big for my shoe. But, and that's because I have this huge arthritic joint right here. So the shoe is the right size and length, but it's never the right size in here. So I have to make more room for my foot. And that's the same issue here. you don't have enough room inside your spine, and so the nerves get squeezed. Was there another term we wanted to
This
attack?
might be controversial, but I've gone to different physicians, and I got different answers from different ones.
I love that question.
All in the same field.
So here's the problem with back pain in general, or spine issues in general. If you have a heart attack, who do you see?
Cardiologist, I hope.
Yes. And if you have a stroke, who do you see?
Cardiologist, I guess.
No, a stroke in the brain, you would see a
Neurologist.
neurologist.
Gotcha.
If you have an ulcer in your stomach, who do you see?
I don't know.
You see a gastroenterologist.
Gotcha.
Okay. If you have a sore throat or sinus problems, who would you see?
That'd be internal. Yeah.
You would see an ENT, an ear, nose, and throat doctor. I'll make it easier. If you had an eye problem, who would you see?
An eye doctor.
But if you have a back attack, you could see a physiatrist like myself.
Okay.
You could see an orthopedic surgeon. You could see a pain doctor or an anesthesiologist. You could see a neurosurgeon. You could go to your internist. You could go to a family practice doctor. You could go to a chiropractor. You could go to a physical therapist. And the list goes on and on and on. So there is no backologist. Like if you have a heart attack, you go see the heart doctor. You have an ulcer, you go see the stomach doctor. But if you have a back attack, there's all these layers of different people you could see. So nobody has cornered the market. And so what you're hearing is the truth according to me. If you go see somebody else, what you will hear is the truth according to them. And if there was a real truth, if there was a one universal truth in this field, there would just be one specialist that would provide the care, much like in ophthalmology or ear, nose, and throat, or cardiology or gastroenterology. You follow me? And that's why you get so many different answers. Okay?
Very good.
So tomorrow we plan on trying to put medicine into this disc and hopefully into this little protrusion via the disc, and we hope to do that live as well for you. So try to tune in tomorrow, okay? Thanks, Paul.
Yep.